Our next guest is Dr. Anthony Dominick of Cape Fear Cancer Center and the Novant Health Medical Group. Dr. Dominick, thank you so much for coming on my show today.
You were very welcome. Thanks for having me.
I am really excited to learn about you. So let's start with your education and your background. Where did you go to school?
Yeah, so I'm originally from Kansas, actually, but ended up going to college at Loyola University in Chicago.
Nice.
And then I went to medical school at Lake Erie College of Osteopathic Medicine in Florida.
Oh, in Florida.
And then I completed my residency and fellowship training back in Kansas at Kansas University. And then I started my first job here.
Oh, so this is your first stop.
It is, after fellowship.
I'm curious. I always like to ask this of people who didn't grow up here. What brought you to the coast?
Yeah, so it's a funny story. So I obviously did my medical school in Florida and fell in love with the ocean. I've always wanted to come back to the ocean.
Yeah.
And so when I was looking for places to apply for jobs, I'm like, okay, well, it's warm down here and these are nice areas. So I started applying to jobs. And then one of our partners, Dr. Lindsay Prochaska, and I actually trained together.
Oh, nice.
And so she works at the group over in Wilmington with me. And I didn't know it when I applied. And she was like, get here on a plane immediately. She's like, you have to come out here. And so I flew out here and kind of fell in love and came back and still loved it. And now I'm here.
Yeah, it's a great place to live. We've been here 23 years, my husband and I, and
it's beautiful.
We call that home. So I understand you're an oncologist with Cape Fear Cancer Specialist, and that you see patients in Leland 3 days a week. So tell me a little bit about Cape Fear Cancer Specialists.
Yeah, so we treat pretty much all kinds of cancer with some few exceptions that we would have to send outward. There's currently 10 physicians practicing. We have an 11th physician starting in a couple weeks. We have two main locations. Our first one's in Wilmington next to the hospital, and then we have a satellite campus that's out in Brunswick to serve sort of patients in the more inland regions of the coast. And we pretty much provide most of the same services at both of those places. And a lot of the doctors rotate between the two locations.
As ours do too. So that's an easy drive for folks from this end of the county to Brunswick Forest.
Yeah, absolutely.
Yeah. So the Brunswick Forest location, they have on-site laboratory and pharmacy, correct?
Yes.
And I think you do some infusions there. Is that correct?
Yeah, so we pretty much have the capabilities of doing everything that we can at the hospital with the exception of blood transfusions because we don't have a blood bank at that location. And so patients come out there, they get their labs are back before they see me, and then they get their treatment. So usually the lab turnaround time is between about 5 and 11 minutes.
Oh, wow.
And so by the time they're waiting for me, getting roomed, vital signs, that sort of stuff, it's usually back and we're ready for treatment by the time I see them.
Oh, that's
so it's really nice.
That's nice. Well, I understand that you have a clinical interest in hematology.
I
correct?
do.
And I don't know that everybody knows what hematology is. So can you sort of give us the generic version of hematology?
Sure. So and our training is combined. So we do oncology, which generally refers to cancer, and then we do hematology, which is everything related to the blood.
Okay.
And so there are lots of blood disorders that are cancerous and non-cancerous. And so as a kind of being interested in hematology, I'm kind of interested in those problems that folks can have.
And I understand that you see benign and malignant hematology patients. So talk to me about the difference. Why would you treat somebody that's not malignant?
Yeah, absolutely. So there actually is a huge need out there, and there are a lot of patients that have abnormal blood counts, and all of your blood counts come from your bone marrow, which is kind of our organ that we claim in hematology. And so if patients have elevated blood counts or low blood counts, oftentimes their primary care doctors don't exactly know why that is. There's bleeding, clotting disorders, things like that people accumulate over time, particularly a lot of blood clotting issues with other medical problems. And there's a lot of questions as how does this need to be managed? Do we need further workup? And when patients kind of have complicated medical issues, we're sort of in tune to sort of teasing out how that needs to be managed. That oftentimes gets kind of sprinkled in with the rest of cancer care, just because there isn't usually a huge interest for that. The malignant hematology is what we call liquid tumors, where it is cancerous. And
liquid tumors?
We call them liquid tumors instead of solid tumors, meaning they come from the bone marrow. So things like lymphoma, acute and chronic leukemias, multiple myeloma are more referred to as liquid tumors, whereas like a breast or a colon cancer would be a solid tumor.
Yeah, I see that. I'm curious, is there more hematology the need for hematology greater here in this area for any reason?
So I think that there are fewer people probably interested in hematology in general, but I think it's probably kind of a need across the board. You know, as our patient population is aging, there's a lot of people moving down from the north. It's an older population.
Right.
And so those are the people that are having problems with low blood counts, anemias, blood clots, that sort of thing. So I think it kind of comes with everything.
Do you have any idea about misconceptions on cancer treatment? Do you hear things about that?
I do, and so we were just kind of joking about this, but I'm one of the younger ones in our practice, and so the time that I have trained in hematology and oncology, we're able to get a lot of people through treatment. And so probably the biggest misconception that I have is somebody will come into my office, we talk a little bit about you know, their diagnosis and what we need to do to treatment, and their initial response is, I'm not getting treatment, my neighbor got treatment and died from the treatment. But our supportive care and the treatment that we use has really been revolutionized the last 5 to 10 years. So the types of treatment that we use, the way that we manage side effects of treatment has changed and improved significantly to really make a lot of cancer care manageable so that patients can really live their life while they're undergoing treatment. You know, that's not always the case, but it has improved substantially. So that's probably the biggest, you know, misconception is they know somebody who tolerated treatment very poorly. And one, the treatments probably have changed, and two, we're better at managing those side effects. So that's probably the biggest thing.
I know this question isn't written here, but I'm going to ask it anyway. Talk to me a little bit about the method of administration for chemotherapy. There's lots of different ways to get it, correct?
Yeah, absolutely. And that also has changed quite a bit because, so traditionally chemotherapy was given in the IV. So the patient comes in, gets an IV
That's
hooked
what
up,
I always think
or they have a port and they're kind of hooked up to the pole, which is what you see in the movies. That is no longer the only way. So we have chemotherapy that we inject with injections, just kind of going underneath the skin. We also have it in pill form. And those are probably the three most common ways that we administer it.
Well, I was just curious about that. Let's talk about recommendations for screening tests. I know this is October and it's Breast Cancer Awareness Month, so it's in the forethought of all of our heads. So how important is it for people to get their mammograms and keep up with those things?
So, you know, in several studies, mammograms have shown in breast cancer as a whole, and what I tell patients when they come to see me, so early stage breast cancer, a majority of those women are going to be cured from their disease. Not everybody, but if we catch breast cancer early. Stage 1, stage 2, stage 3, a majority of those women will be cured of their disease. The way to catch it early is to do those routine screening mammograms, which generally you should talk to your doctor about starting at 40. Definitely after 50, but even starting at 40, you know, most insurances and things cover it because it's a preventative measure, just like anything else. And if you're going to catch it early, your chances of surviving that breast cancer are going to go up significantly, as opposed to if it's caught late.
I know this pandemic has really put a hurting on us getting out and getting routine physicals and exams and what have you. And more importantly, they just need to go ahead and do it. In order to catch it early, you have to have those mammograms.
Absolutely.
And I think we would be remiss if we didn't talk about the importance of having a primary care physician. Because they can keep track of those tests and the screenings that you need to have done. And especially if you're part of our group, you have my chart. So you have all those little things that pop up and say you're late for your mammogram, you're late for your colonoscopy. And so that really helps too. Are there any other cancer screenings that you feel that patients should pay attention to?
Yeah, so, and there actually was there were a couple of recent changes, and one big one I want to talk about that I think it's a good question. So colonoscopies have long been known to do the same thing. So, what a colonoscopy is the doctor goes inside, and if they see a polyp, that polyp has the potential to develop into a cancer, and so they remove that polyp.
Right.
Unfortunately, we're seeing younger and younger people get and die from colon cancer. And so recently the CDC changed their guidelines. Initially it was start your screening at 50. Now it's 45 because we're seeing a lot of young people with colon cancer. Most people know about colonoscopies because they've heard somebody have had it.
Right.
But that age has changed, and I think most people are catching on with that. Probably the biggest cancer screening that I see missed here since I have started, that I probably order a couple a day, are people who have smoked for what we call 20-pack years, meaning that if you take the amount of cigarettes that you smoke, so 1 pack would be 1, and multiply it by the years that you smoke. If you've smoked more than 20 pack years, you should have a CAT scan of your lungs every year from age 50 to 80. And it is very common that I have somebody come to my clinic for a hematologic problem, and I smell the smoke, or I ask them about smoking, and I ask them, have you had your lung cancer screening? And oftentimes they either have not had it, or they tell me they have a chest x-ray. Again, kind of going back to what we talked about breast cancer, so catching lung cancer early is how we cure people from it, not catching it late. And so they had done some studies several years ago, and it showed that, hey, if we screen these high-risk patients, we're able to not only catch these lung cancers sooner, we're able to cure more people from lung cancer. So that's one that I personally have been kind of promoting quite a bit, because it's definitely less heard of or less recognized than the other two.
Yeah.
And that came out a couple years ago. And just because I deal with cancer a lot, for me it's like one of the top things I talk about, but it may not be known by everybody.
Wow. What great information.
Yeah.
I'm sorry I haven't had you on sooner. And I think there's so much more to talk about. So
Absolutely.
I'd love for you to come back.
I absolutely would love to.
Well, thank you so much for being here today. It was a pleasure to have you.
Thanks for having me.
You're welcome.